Everyone. We are recording now. So today's Grow Echo didactic is being provided by Dr. JDrost, and the case will be presented by Donna Barrett. Dr. Drost completed her internal medicine residency in geriatric hospice and palliative care medicine fellowships at Summa Health. Currently, Dr. Drost works at Summa Health and serves as the home-based primary care medical director and routinely sees homebound frail older adults and their families in their homes. Throughout her practice, she focuses on ensuring patient-centered care while optimizing the interprofessional team. Dr. Drost is the Geriatric Fellowship Program Director at Summa Health. She's also the Research Medical Director at Summa Senior Institute. Donna Barrett received her Master's in Social Work at Cleveland State University. She is Program Manager of Senior and Adult Services at Summit County Public Health and the Principal Investigator on several federal Health and Human Services grants, including an Alzheimer's Disease Program Initiatives grant. Donna oversees the Gatekeeper program, which provides identification of at-risk older adults and assists them to access the services and resources they need to remain safe and independent in the community. And just a few housekeeping notes before we begin. Please mute yourself during the presentation. To communicate with the group, use the chat function and share all chats with the entire group. If you are on by phone, use *6 to mute and to unmute. Please make sure your name shows on the screen, and again, as well as your face if possible, so we can become more familiar with each other. During the case presentation, you can unmute to participate in the discussion if you wish. Just so you're aware, today's session is being recorded, and also be aware the details of the case have been changed to ensure patient privacy. At this point, I'm going to turn over to Dr. JDrost. Jen?
Great. Let me just a minute. We'll get things sorted and situated here. This, and then let me pull up the chat as well, just in case folks prefer to. Gotta get to the beginning to get started there. So, all right. Everybody should be seeing the title screen, kind of blocky, multiple colors, etc. So, as Margie said, as already introduced, I'm Jen, and today we're going to talk about the importance of screening for dementia and cognitive impairment, particularly in primary care. But I think it's especially important as we talk about roles within the interprofessional team to recognize that while diagnosing a dementia may be something that we have to delegate to certain members of the team, certainly having an understanding and awareness of screening tools available can be applied across that interprofessional team. So it doesn't just have to be the primary care provider or neurologist or geriatrician who's doing dementia screening, but really encouraging everybody who is interacting with folks to participate in this process. And so dementia and cognitive impairment is under-recognized and under-diagnosed. Lots of good studies that prove this. And in fact, I'm just going to pull this up real quick. So this was actually an article that was texted to me yesterday, brand new, hot off the presses, kind of in the News Channel 5 at Cleveland about a new study that just came out. Oh, it's going to blur. Anyway, that shows that 1 in 10 Americans over 65 has dementia, and yet less than probably 25% of those are actually diagnosed. So it is under-recognized, and a lot of reasons for that. In healthcare, particularly at doctor's appointments, we are kind of being delegated to shorter and shorter patient encounters, and so really business focus, really problem focus. What are the chronic illnesses that are already in the chart? What are the concerns that an individual is bringing to us? And not always having that opportunity to look at the complete picture of an individual. There's also a misunderstanding of kind of those changes that do occur normally with age. And there are cognitive changes that occur. And yet these cognitive changes that occur with normal aging should not be impacting those day-to-day activities, the ability of an individual to take care of themselves. There's also this process of minimization and normalization of symptoms. So how often we hear from folks, oh, I never keep track of the day, right? I'm retired, I never think about it. And yet in the majority of people's lives, there's enough cues, there's enough daily activities, birthdays, holidays coming up, catching bits and pieces in the news that, while I might not take me a minute to think about what day of the month it actually is, pretty clear that it's, October, that Thanksgiving is just around the corner, and so is, Christmas, and certainly the year. So there is a lot of that minimization, normalization that can occur with patients and with family members then as well, in order to kind of brush those symptoms aside. And then even when some of those symptoms start to become appreciated or recognized, it never fully gets evaluated or diagnosed. A lot of those same reasonings for kind of why it's under-recognized, but then under diagnosis, what do we do if we're worried about it? What training is there? What are the screening tools? And then, if you screen positive, that doesn't give you a diagnosis, that raises the kind of flag that here's a concern. But what are those next steps that can be taken? There's also a perception that nothing can be done, right? We don't have really good medical treatments in order to stop, halt altogether, and certainly nothing that reverses the memory or the cognitive loss that's already happened. And so this kind of, it's futile to go through this whole process, to put people and their families under this level of strain, perhaps, because there's nothing that we can do about it, which is really not true. But there's certainly that perception. What doesn't help is that across professional societies, the value of screening is controversial. And the biggest thing is that limitation in effective medical treatment options that, again, halt or reverse cognitive loss. But there are many professional organizations. So like the USPSTF, which is kind of the national coalition that determines our screening protocols for various disease states, including dementia, but cancer recommendations, et cetera, really has found that screening, offers no clear risk of no clear benefit, but also no clear risk of harm in there. So it's that intermediate. There's really not a lot of data around there. Whereas other organizations, including the American Geriatric Society, the American Neurological Association, Medicare as well, have all concluded that screening is important and is actually a part of the Medicare annual wellness visit. So some of those benefits. So as we talked already, medications are pretty limited. Lots and lots and lots of research still going on around this, but medications have been shown to slow the progression and help to maintain function for individuals, particularly when diagnosed and evaluated earlier in the disease course. So there are options. It also allows patients to really be engaged in their treatment plan, to understand their diagnosis, to understand the challenges that may come either now or in the future. Whereas if we wait until people are late in the disease course, we're really not affording them that opportunity to participate in their own medical care. It allows us to talk with patients and families about how are we supporting them to minimize the risks of harm. I put down here our 4 M's that we like to focus on because these are some of the more particular areas. So money and finances, the risk of financial exploitation, medications, and focusing on people taking medications appropriately, not missing doses, not taking too many doses, as well as choosing effective medication regimens that limit the risk of harm. Mobility, particularly around driving, another area of high risk, and then meals and eating. So it's kind of our thought of like, these are kind of 4 risky areas that we need to talk about even early in the disease course. And as we do that, we allow that time for patients and their families to implement routines, to talk about healthy lifestyle, engaging in changes that have also been shown to slow the progression of the disease, and certainly to prevent secondary illness harm. Healthy lifestyle helps to protect the heart, helps to prevent heart attacks and strokes as well, which is only going to further complicate somebody's healthcare if they do have a diagnosis of dementia. And then participating in advanced care planning. So lots of benefits to screening and establishing a diagnosis. And there are a lot of screening tools, and we'll talk about a couple of these here. So the mini-cog, the list is here. We're going to talk a little bit more specifically about the mini-cog, the Montreal Cognitive Assessment, so the MoCA, and the AD8 Dementia Screening Interview, and show some examples here. But again, there are a whole list, and this is by no means an exhaustive list at all. Some of the things here, obviously the Folstein MMSE is probably one that people are really familiar with when we talk about a mini mental status exam. Lots and lots of research, lots of validation around it. Somewhat limited in general practice because it is copyrighted, though it does still get used. The Brief Inventory of Mental Status, the BIMS, is the tool that is primarily used in nursing homes, nursing facilities in order to, assess cognitive status is one of the things that is reported in the MDS in the facilities. So you might see numbers coming from there. And then the Memory Impairment Score, again, this is another one that is used actually probably a little bit less in a screening, but as part of a battery for diagnosis through neuropsychological testing and also in research. Limitations to screening. Positive screening does not equal a diagnosis, right? It's raising that flag that there's a concern here and we need to do more. The goal of screening is to identify non-clinically apparent disease prior to its becoming clinically apparent, which is kind of a little funny sometimes when we're thinking about cognition and cognitive impairments, but that is typically the goal of screening. When we talk about cognition and dementia, a lot of times we're talking about screening and how it applies to, again, that first step into diagnosis. Screening and screening tools in and of themselves do not determine etiology. So dementia is a clinical syndrome that has a lot of different potential causes and a lot of potential interacting causes as well. And so just because you screen positive on a tool does not mean that you have Alzheimer's disease. It doesn't mean that you have a Lewy body dementia. That more evaluation needs to be done. Positive screening does not determine capacity. And I think this will bridge into our conversation a little bit later with our case. Just because somebody screens positive, that in no way, shape, or form indicates what kind of medical decision-making, what kind of financial decision-making capability this individual has. And in fact, even establishing a diagnosis, again, it's a flag, but it is not, it does not say if that person has capacity, if that person needs a guardian, et cetera. Each tool has a different set of cognitive domains that it may be looking at and addressing, and that's both some of the strengths of the different tools as well as some of the limitations. We'll talk a little bit more about that. They also have different measures, total score, how many points that is out of, as well as what the different scoring is, and they aren't interchangeable. So a score of 30 on a mini mental status exam, a score of 23 on a mini mental status exam is not the same as a score of 23 on a MoCA or on a SLUMS. BIMS is a 15-point scale, so it all kind of varies a little bit. And then some general barriers to accurate screening. So vision and hearing impairment can be a big challenge, particularly when we're talking about older adults. And while there's a way to, navigate perhaps around that on a lot of tools. We do have to keep in mind that these tools have been validated. So somebody who has vision impairment, telling them that this is a picture, like on a mocha, right? This is a picture of a rhinoceros, and giving them the word and then asking them to come back and name them, right? We worked around it, but we totally invalidated the tool as well in the process. Baseline education and intellect also plays a role. People who have literacy issues certainly face additional barriers to completing many of these tools. And then mental health concerns play a role as well. One thing that's not on this list is there are some tools that require drawing as well. And so people with mobility impairments, arthritis in their hands, tremor from Parkinson's or other tremor causing illnesses may also have an impairment or flag as an impairment on this when it is a functional thing. So those are all considerations we need to keep in mind. So we'll switch gears and talk about our tools, again, starting with the mini cog. So this is, it's a 3-item recall and a clock drawing test. That's the CDT. So it's pretty simple, pretty straightforward, quick to administer. There are resources available in order to provide some training for standardization for individuals. It is available in multiple languages, and on their website, there are actually 21 different language versions that can then be administered. I think that's another caveat to the utility of testing is language barriers. And for folks who are not, primary English speakers, that becomes a challenge. Again, you can get around this in using a translator to help you to translate, but they've not been validated in that situation. So we do have to remember that versus using a primary, a tool that's primarily in the native speaking language. But then I don't speak most of those languages either. So that becomes an additional, potential barrier. There are also multiple versions that we'll see here about the, word list that we use for that 3-item recall. So it does allow for some repeat testing. But as a potential barrier, as a screening tool, some studies do show that the mini cog can miss up to 25% of folks who do have a cognitive impairment. So it's quick, it's easy to administer, but there is that risk that we could be missing folks in the process. Screen is not actually sharing the projection, is it? So the mini cog, and these are screenshots from what you can download as well. The 3-item recall here, and it even tells you directly like what to say. Please listen carefully. I'm going to say 3 words that I want you to repeat back to me now and try to remember. And so again, you can see the multiple versions. This one is all in English. So you give them those 3 words, they repeat them back. You can give them up to 3 attempts to repeat those words before moving on to the clock drawing test. For repeat administration, they do recommend using different sets of words. And as you can see, these words are a little more complicated than some of the other words that we'll see on our screening tests. These are multiple syllables, longer words to remember along the way. So you give them those 3 words, they repeat them back, and then you say, okay, next we're going to draw a clock. This tool, if you print out this actual full tool, front and back kind of page or 2 pages, it does have a actual circle that they can just put the numbers in. So draw a clock for me. Put in all the numbers where they go. And then when that's done, or kind of as they're finishing them, that's a little like tool, go ahead and tell them, right, and now I'm going to give you a time. So set the hands to 10 past 11. Sometimes if you don't, folks may be a little impulsive and automatically put a time on there. And then you just ask them for those 3 words back. and you can write them down there. And then the clock. So scoring on this, again, you get 1 point for each word that you remember without any cueing. On the clock draw test, if it looks pretty normal, all the numbers are in the correct position, in the correct order, there's only the numbers 1 through 12, nothing duplicated, nothing missing, and the hands are pointing generally to the 11 and the 2, you get 2 points. If it's abnormal or they're not able or refuse to draw, then you get 0 points. And so you total of that. And the cut score on a mini cog is 3. If you want to be even more sensitive and make sure we're missing fewer people, you can do up to a 4, but it's been validated at that 3. Pause. I do see a few comments here on doing the mini cog. I think one is, it seems none of my patients know how to divide the 12 sections of the clock. Yeah, so the clock drawing test is a pretty high example. I mean, it's got visual spatial cueing, but the bigger thing is it's organization, it's frontal lobe, it's executive function. So it is planning and organizing in order to do that. While it's not specifically on the mini cog, as people are doing that, right, if they start at 12 and then go 1, 2, 3, 4, 5, 6 and all the way around, that shows or demonstrates a less refined planning process to it versus somebody who starts with the 12, puts a 6, goes back to the 3 and 9, right? Very ordinal, very planned, and then can fill in those other numbers around. So it is, right, the not being able to judge how far around the circle my 6 needs to go. How do I wind up with my 11 right next to my 12, right? That's all that planning, that thinking, that organizing process that you can get some of those cues about how a person is approaching by watching them do this too. For the MoCA then, so the Montreal Cognitive Assessment, this is a 30-item test. It evaluates multiple cognitive domains, including a considerable group of executive function / visual spatial activities. So we do get that automatically in this test as well. Benefits is it is standardized. There's actually a whole certification process that you can sign up and do on their website. So at the www.mocatest.org, you can go there and get a certification and an education process in how to do this in a way, again, that maintains and optimizes kind of the validity, the accuracy of it. There are, again, multiple different cognitive domains that we're looking at. And as we start to think about diagnosis, as we're looking at those patterns of where the cognitive domains are affected, we can get a better idea of where, what type of dementia this is. It has been validated across many different dementia etiologies, so Alzheimer's, actually just about all of them, to be honest, whether it's Alzheimer's, Lewy body, vascular, Wernicke, like the whole picture. And there are multiple versions in multiple different languages, again, that allows for repeat administration. Their website did not allow me to easily count the languages available, but I would say it's at least 20, if not 30 at this point in time. Interestingly, they also have versions that are validated for folks who have vision or hearing impairment. So again, allowing us to have a tool that we can better utilize in people who do have those impairments. And they have a phone version as well. So height of COVID, we were doing a lot of telehealth visits. This did allow us to be able to track and monitor our patients on those telehealth visits as well. Limitations, this is a more challenging test. And so folks who do have lower education or lower, baseline intellectual abilities may have lower scores on this test as a result of that versus as a result of developing cognitive impairment, or may overemphasize the severity of their cognitive impairment as it relates to their functional ability. So again, some screenshots of the original 7.1 version of the MOCA. Starting in this top section up there is with the visual, spatial, and executive functions. There's a trail test where they alternate between numbers and letters to connect the dots. There is a draw, so we can start. This one has the necrocube on, but there are different shapes that are trying to get the ability of an individual to kind of grasp that 3D concept and repeat. So lots of different versions on that. And this already includes a clock draw test that is 3 points. So contour, numbers, hands, and generally is the contour circle, are the numbers generally in the right place, are the hands generally in the right position. And again, that training process goes through much more precisely how to assess when you give people credit and points for that. All of the versions have 3 different animals that folks can name. Looking for that anomia, that's pretty common with like an Alzheimer's type of picture, not being able to name that. Clinically, this version has a rhinoceros on it. There's another version that has a hippo on it. Those two get interchanged really, really commonly, to the point in our like consensus conferences and stuff. We just, kind of laugh over the hippo rhino syndrome that occurs. But you often see that with folks, specifically on this version, but a lot of animal misnaming. And then looking at memory, the MOCA has a 5-item recall, but you can see like the I don't say quality of the words necessarily, but the complexity of the words that are used on the MOCA are easier than on the mini cog. So a little bit more straightforward. We have tasks on there that look at attention and working memory for individuals. There's also some serial calculation, subtraction of various numbers, starting at different numbers based on what version you're using. And then some language activities, repetition, again, the ability to listen, to remember, to state them correctly, and lots of kind of those interjecting words in these sentences. Naming and fluency. This is the one that I practice because you give it to me and I blank out. So I practice this one. It's also kind of fun. So how many words can you think of in a minute that start with a specific letter? And that's provided for you. Abstraction. So this is that can we, how concretely are we thinking? Right. So a train and a bicycle. Trains, most still do have wheels. So a train and a bicycle, right? Like, how are those similar? We have wheels. Well, that's a very concrete answer versus abstracting that to more of that category, their forms of transportation. Recall. So how many of those words can you bring back? How many of those words can you, which is the total score, but then also giving people the opportunity to bring things back with some cueing. Again, kind of showing how the brain is working a little bit differently, and then some orientation questions. Total out of 30 points. And again, there are different cutoffs for, a positive screen. Positive screen really being anything less than about a 26 on this. That would raise the concern, is there something else going on here? And then the 88, and again, this is available for download through the Alzheimer's Association. It's an 8-item test, and it looks at, it's actually caregiver or respondent report, that if folks get a score of 2 or greater, then cognitive impairment is likely to be present. This is probably not going to quite project correctly, but looking at, that respondent, caregiver, family member, providing information on, are they witnessing problems with judgment and decision making, a change of interest or ability to participate in activities or hobbies? Are they repetitive? Are they having trouble learning new tools? I giggle on this one that we're still looking at a VCR on it, but you know, you get the points, you know, their new iPhone or a new phone that folks get. You know, are they disoriented to time and place, trouble managing their finances or making it to appointments? And then just daily problems, you know, generally that people are needing. And if they say, yes, there's been a change on at least 2 of these things, then that would be a positive screen as well. All right. So a couple of quick screens that we can use. Again, the mini cog and the MOCA both have training modules, the MOCA kind of being the most formal that you can get official certification with. But as you can see, most of these you know, are straightforward, that really we can all utilize at least some of those skills in order to be able to kind of capture folks who might be at risk of having a dementia. I am going to stop screening or sharing there. Open to questions, or we can talk at the end.
I'm checking the last, you addressed the last question, so, or comment. Does anyone else have any questions or comments for Dr. Drost?
Question. This is Amy from the Alzheimer's Association. Question about the AD8. Is this something that you would recommend is administered when a concern is brought up and that caregiver is attending the appointment? Or is there another way to pair that with another test during the visit? Like, when do you recommend that you're using the AD8?
So clinically, we rely on the AD8 a lot when we feel like there is that language barrier, recognizing that, you know, for folks in our area, especially, we do see a lot of our Nepali refugee folks. And we use a translator to gather more history and information, but again, utilizing that translator to actually complete the cognitive assessment has not been validated, versus the AD8 is much more conversational. So even if we're using a translator for that, it seems to work out a little bit better. I think it is also a formalized and pretty quick way to also get caregiver or family input without necessarily pulling them aside or having a you know, a long conversation in a busy, you know, primary care clinical practice. You know, daughter or son brings patient in and they can fill this out while you're doing this with the patient, you know, doing a mini cog. And getting both in a pretty condensed way. So I think that would be another great way to incorporate the AD8.
Any other questions? Thank you, Jen.